Hi, and welcome to this module on biophysics of injury in motor vehicle crashes. I'm Stuart Wang, a trauma surgeon at the University of Michigan and also director of the International Center for Automotive Medicine. Let's start off by talking about injury. Injury results when tissues are disrupted by local concentration of physical forces. For an injury to occur, loads must be applied to tissue in a manner and with enough force to exceed the strength and tolerance of the tissue at that location. There are a number of different loading modes that can occur in motor vehicle crashes. One is tension or pulling. That, for bones, tends to result in a transverse fracture. You can also compress along the long axis of the bone, which tends to result in an oblique fracture. You can have bending, which results in a butterfly fragment, or you can also have twisting, which results in typically a spiral-type fracture. Let's imagine that a long bone is being bent by this strong force downward on the two ends. What will happen is the upper portion, right in the middle, there's tension. It begins to pull apart, and that crack propagates downward, and eventually it just separates and it creates that butterfly fragment. So what generates these forces in a crash? So let's talk first about inertia. Inertia is a property of matter that resists changes in an object's motion. Remember Isaac Newton's first law of motion. An object at rest tends to stay at rest, and an object in motion tends to stay in motion with the same speed and in the same direction unless acted on by an unbalanced force. But once again, a body in motion continues in motion. This is a nice little poster that I found on the web, and it says, inertia. Your truck has brakes, the massive hunk of stone doesn't. And you can see that when this truck tried to brake very hard, that stone slid along the flatbed of the trailer behind it and came through the front and into the driver's cab. So what happens in a crash is that the vehicle comes to a sudden stop. So let's think about stopping the forward momentum of a thrown egg. This is a video here showing someone throwing an egg at a hard surface at about 40 miles an hour. The egg splatters. When he throws the same egg at a sheet, that egg goes from 40 miles an hour to 0, but it remains intact. Why is that the case? When the egg strikes the hard surface, it decelerates from 40 miles an hour to 0 in a very short period of time, which means that there's a very large force which exerted upon it to stop it in that short period of time. When the egg strikes the sheet in the second example, it slows from 40 miles an hour to 0 over a longer period of time. Hence, the force that was exerted on it to stop it is much, much smaller. And we all know that a smaller force is less likely to cause injury. The video on the right shows an airbag inflating in slow motion. And you can see that it's almost the same concept as having that sheet in front of it. What it does is it provides a broad surface against which the occupant can react and slow down over a greater period of time. Let's look at this frontal crash video in light of the things that I just talked about. The car comes to a rapid stop. The occupant keeps going forward until he's slowed down and stopped by the seatbelt in the airbag. Let's look at this real-life case. This is a case where there's a family traveling an SUV coming in from the left, and there's another vehicle coming in from the right, being driven by a young driver that loses control because he's not paying attention. He overcorrects, goes into a yaw, comes across the median, and is struck on the right side by the case vehicle. You can see the resulting damage. The SUV on the left has a lot of damage across its entire front, so the SUV experiences a frontal crash. The other vehicle, the struck vehicle, sustains very significant damage with a lot of intrusion into the occupant compartment, and the driver of this struck vehicle was dead at the scene. Our case vehicle had 3 child occupants aged 3, 6, and 7. The 3-year-old was in the left rear, the 6-year-old was in the right rear, and the 7-year-old was in the right front. In a frontal crash, and you can see from the modeling video on the bottom, see that the occupant keeps going forward until they're arrested by the belts. Notice in the video also how the heads of the occupants try to keep going forward, and the thing that slows them down and stops them is the neck. Let's look in a little bit more detail at the crash result of the 7-year-old right front passenger who had a lap and a shoulder belt. You can see the video there detailing her motion. You can also see in these pictures that she had shoulder belt marks across her right upper chest and shoulder. You can also see the belt marks across her lower abdomen and pelvis. This child sustained the bruises as you've seen there, but also she sustained an atlanto-occipital dislocation, which is a disruption of the connection between the head and the upper part of the neck. We saw evidence of this with bleeding noted on the CT scan of her upper neck. The head bone is connected to the neck bone, and it's good that it remains that way. Now remember, during the crash, her body was stopped by the seatbelt, but the head and the arms and the legs kept trying to go forward. The head in a child is larger relative to the rest of the body, and it tries to keep going, and it's held back by these connections between the upper neck and the base of the skull. You can see on the picture on the right, which is of a fatal atlanto-occipital dislocation, what happens. You notice that large gap there between the upper neck and the skull. And what's happened there is that the tension from the head trying to travel forward has pulled it off the neck. Let's look at what happened to the brother, the 6-year-old right rear seat passenger. Now, this child had a shoulder belt that was behind his back and had only the lap belt on, which was quite slack. He travels forward far enough to strike the back of the seat in front of him, which is where the sister was sitting. Remember that the seat is pretty much a metal frame that's padded. Particularly in the back, the padding is not very thick, and you can see the skull fracture in the upper right that resulted when the right side of his head struck the frame of the seat in front of him. This child sustained skull fractures and brain injuries. He also sustained lumbar, spine fractures, as well as multiple intestinal injuries from the lap belt. He was slouched down, and the lap belt crushed the intestines against his spine. Most interestingly, for this case, this child also suffered the same exact injury as the sister, although more severe, the same atlanto-occipital dislocation. You can see these pictures here that he required operative fixation and a halo. So guess what happened to the 3-year-old left rear seat passenger? Like his older brother, he kept the shoulder belt behind his back. He was also slouched down with the lap belt a bit looser. And this child also sustained multiple intestinal injuries as well as pelvic fractures. He had the same atlanto-occipital dislocation, although the most severe of the three, which is evidenced by the bleeding seen on the MRI on the left and the CT scan middle bottom image. So in this single frontal crash, the adult driver, who was protected with a 3-point belt and an airbag, sustained no significant injuries. The 7-year-old right front passenger had an atlanto-occipital dislocation. The 6-year-old right rear passenger had a more severe atlanto-occipital dislocation, and the 3-year-old left rear passenger had the most severe atlanto-occipital dislocation. All of this is a result of immature necks trying to stop heavy heads. The 2 boys in the rear also sustained a number of abdominal and spine injuries as a result of bad positioning of their lap belt. The lessons learned from this case, I think, are pretty apparent. Injuries are caused by physical forces, hence they're predictable and dependent on the crash event characteristics. All 3 of the children had the same exact injury, which was atlanto-occipital dislocation. The second lesson, obviously, is that the risk of injury is affected by the occupant characteristics. The younger they are, the more frail they are. At the other extreme of age, in the elderly, the same sort of increase in injury risk occurs. It's also very apparent from this case that risk of injury is affected by appropriateness of restraint usage. Now is a good time to discuss the question of how safety system restraints work. Inertia causes occupants of a motor vehicle to be moving the same speed as a car. In a crash, particularly a frontal crash, the car comes to an abrupt halt and the occupants inside it continue with the speed that the car was traveling before until their body is stopped by an object such as a windshield, a dashboard, or such. We prefer them to be stopped by a seatbelt or an airbag. Now, a seatbelt is designed to apply the stopping force to more durable parts of the body over a longer period, helping protect the body from serious injury. We prefer that the lap belt be very low down to engage the bony pelvis, which is the strongest bone in the body. and we'd like the shoulder belt to be appropriately positioned over the clavicle. The airbag is a big pillow which is designed to spread the arresting force over a large part of the body so that those forces that are potentially injurious are not concentrated. Let's think about what happens in a frontal crash. You can see in these videos that the car comes to a stop. The occupants keep going forward until they're stopped by the safety restraints. The picture on the right shows in yellow where the seatbelt should be optimally positioned. You can see that the lap belt should engage the bony pelvis by the hips, and the shoulder belt should cross the sternum and the ribs and also catch the clavicle as well, so that it engages as much as the strong bony structure and avoid directly compressing on the soft internal organs. The airbag is meant to create a large surface against which that entire upper torso, which contains so many vital organs and also the head and the neck, can be safely stopped. This is a picture of my son when he was younger. You can see that his thighs are not long enough, and therefore he's not able to have his feet on the floor or to dangle his lower legs over the front of the seat bottom. This oftentimes leads to slouching so that they can have their feet on the floor or at least their lower legs in front of the seat base. The lap belt then tends to ride up high. The shoulder belt then tends to rub across the neck or even across the chin or face, and oftentimes then children will take that shoulder belt and either put it behind them or stick it under their arm. Seatbelt mispositioning causes the arresting force to be applied to the wrong part of the body, which is much more vulnerable. So in this image on the left, you can see the outlines of the bones and also the internal organs. What's important to remember is that over the abdominal region, below the ribs, there's nothing but soft tissue in front of the spine. So if the seatbelt doesn't catch the ribs or the pelvis, it will crush all of the abdominal organs and keep going back until it loads the spine. Hence the intestinal injuries and the spinal fractures that are seen in lap belt syndrome, which is particularly prevalent in adolescent children. Here's another case where you can see that an improperly worn belt has resulted in severe internal organ injuries. You can see the lap belt mark across the mid-abdomen. You can also see the long incision along the front of the abdomen, which is required to fix her multiple internal organ injuries. And you can also see the long incision along the back, which is necessary to fix her spinal cord injuries. She became paraplegic as a result of the injuries. Let's talk now a little bit about airbags. Stopping an object's motion requires force acting over a period of time. An airbag tries to slow the passenger's speed to zero with little or no damage by increasing the time and decreasing the force necessary during that longer period of time. The airbag has the space between the passenger and the steering wheel or dashboard and a fraction of a second to work with. Even that tiny amount of space and time is valuable, however, if the system can slow the passenger evenly rather than forcing an abrupt halt to the occupant's motion. Previous video, as we're used to seeing, was that of an airbag deflating in super slow motion. This isn't what happens in real life. It's important to remember that airbags have very little time and they're powered by explosive substances. From the time the sensor detects the collision to the time the airbag is fully inflated is only 30 milliseconds or 0.03 seconds. Some 50 milliseconds after an accident, the car's occupant hits the airbag and its deflation absorbs the forward-moving energy of the occupant. This video shows the real-time deployment of an airbag. Just notice how explosive it is and imagine the forces that are being created. Given the explosive inflation of the airbag in a very short period of time, airbags can be very dangerous, especially when occupants are frail or out of position. This video shows a child dummy that's resting against the armrest when a small side airbag deploys. Notice that the force is sufficient to pick up the child's head and throw him and his entire body across the car. Let's look at another example of a frontal crash. In this case, we're going to be talking about the occupants of a 1997 Dodge Caravan coming in from the left. They don't see a 1994 Super Duty truck stopped by the side of the road. The front of our vehicle strikes the rear of the vehicle in front. The case occupant is a driver who's unbelted and restrained only by the airbag. This next slide shows the damage to the front of the car, moderately severe. On the inside, there's minimal intrusion. However, the steering wheel has been bent upwards and forwards. At the scene in an emergency room, the patient complains primarily of hip and right leg pain. Exam shows the lower chest wall and upper abdominal bruising and tenderness. There was also some right leg tenderness. You can also get an appreciation from these images of the size of this case occupant. This occupant sustained bilateral rib fractures, which can be seen on the CT scan on the left, and also sustained a spleen injury, which can be seen in the image on the right. In addition, this patient sustained a right femoral neck fracture and also severe right ankle and foot fractures. Now, the outcome from this case was that the splenic injury bleeding was controlled by embolization in interventional radiology. She had multiple orthopedic surgeries. Because of her weight and the multiple lower extremity injuries, she had a very prolonged rehabilitation and was unable to return to work for greater than 9 months. The cases that I've shown illustrate the most commonly injured body regions from frontal crashes, which are first to the lower extremity, second to the pelvis, third to the chest, fourth to the head, and fifth to the abdomen. For all occupants, particularly children that should be in booster seats, have a much greater risk of abdominal injuries. Current data shows also that since the advent of frontal airbags, head and facial injuries have become much less common. Chest injuries are still common, but aortic injuries and heart injuries have decreased as the airbags have done a much better job of preventing contact of the chest with the solid structure of the steering wheel and the dashboard. However, what we've noticed is an increase in lower extremity injuries. Most specific anatomic injuries that result from frontal crashes are femur fractures, pelvic fractures, rib fractures, followed by closed head injury, lower leg or tibia and fibula fractures, hemothorax and pneumothorax, forearm wrist fractures, pulmonary contusions, C-spine injuries, facial fractures, liver, and splenic injuries. The last case that I showed, I think, also illustrates another physical principle. More mass equals more inertia. The patient that we had was very large. Remember that inertia is a property of matter that resists changes in an object's motion. An object's inertia is directly proportional to its mass. So the heavier an object is, the more inertia it has, and the more force that has to be exerted to stop it. We're all aware of the obesity epidemic that's affecting our country. So a question that I might ask you is, how do you think obesity affects crash injury? Let's think again about what happens in a frontal crash. The video on the upper left shows the motion of the body until the force is exerted by the three-point belts to stop the torso. The image on the right shows an inflated airbag, which is exerting a force over the head and the upper torso to slow it down before it gets to the steering wheel. On the bottom are two images, one of a thin individual and one of a larger individual. You can see that the spine is about the same size. However, the dark gray represents the fat, and you can see that the person on the right has a substantial amount of fat on the inside. This is the visceral fat, and also a very thick layer of subcutaneous fat covering the entire body. How do you think this might affect injury risk in a frontal crash? One of the things that we did was to study patients that had been involved in frontal crashes. And what we did is we took a CT scan, we took a slab across their body, and we measured the amount of fat. In the image on the right bottom, you can see that we've measured the volume of subcutaneous fat at a level of the third lumbar vertebra, or L3. What we found was that obesity, as evidenced by the amount of subcutaneous fat, decreases abdominal injuries but increases lower extremity injuries in frontal crashes. The graph on the left shows the amount of subcutaneous fat volume on the left and the injury severity to the abdomen along the bottom. The fatter patients don't get any severe abdominal injuries. On the right side of the graph, you can see the same plot of subcutaneous fat volume on the y-axis versus increasing severity along the bottom x-axis. There is an increase in greater severity injuries to the lower extremity as one gets fatter. This graph shows the effect of obesity on lower extremity injury region in frontal crashes. The obese occupants have a markedly increased chance of hip fractures, which include femoral neck fractures. If they're obese, they also have an increase in tibia and fibular fractures, as we saw in our last case. These three-dimensional reconstruction of the CT scans shows some examples of the type of fractures that we see in our motor vehicle crash occupants. You can see a very badly shattered knee. You can also see the hip socket fracture on the right-hand images. These are some CT reconstructions of tibia and fibular fractures from obese occupants, but you can see just how badly shattered that lower leg is right by the ankle in these images. Not only are the injuries more severe in the obese patients, they get nearly double the number of lower extremity fractures. You can see in this plot here the number of fractures to the lower extremity in the normal population versus the obese population. You can imagine what a big medical problem this is. Obese patients have a much harder time with rehabilitation, and when they have fractures, they're putting a lot more weight on them when they're trying to get about, which again increases the number of complications and delays their recovery. This plot shows the effect of obesity on regional maximum abbreviated injury severity score in side impact crashes in the different body regions from 1H, which is to the head, a 2 face, a 3 neck, 4T or thorax, a 5A or abdomen, 6S or spine, a 7U or upper extremity, and 8L or lower extremity. In contrast to frontal crashes, lower extremity injuries are about the same between normal and obese occupants. You can see the significant increase in abdominal injuries with obesity. Remember, in the frontal cases, we saw a decrease in abdominal injuries, but with side impact crashes, obesity leads to an increase in the severity of the abdominal injuries. Let's examine the physics of why this might be the case. In this next real-life crash case, a 19-year-old female is driving along and loses control on a wet, unpaved road. She goes into a yaw and slides into this tree. Well, this is a picture of the car that she was in. You can see it looks like a banana from the top view. Let's look at a video that's very similar to the crash, although there's much more damage to our vehicle than is seen in this crash test. You can see this car sliding into this pole. You can see that the pole comes in, and because there's very little crush, the occupant is struck directly and pushed across the vehicle. So a side impact crash is very different from a frontal crash. Remember that in a side impact crash, essentially the occupant is falling against the restraints and hopefully never gets to the solid vehicle structure. In a side impact crash, in contrast, what happens is that the door very quickly picks up the speed of the intruding vehicle and strikes the occupant. So you can imagine that a fatter occupant is much closer to the door and picks up much more force as that door intrudes in. This interior view of our case vehicle shows severe intrusion of the door and the B pillar into the occupant space. The seat and the seat back are severely deformed, and the center console has been crushed as the seat structure on the left has been pushed towards the passenger side. This view from the back seat shows the intrusion from a different perspective. Notice how the B pillar has come in to the midline of the vehicle. Completely predictably, this driver sustained contusions to her left posterior lung from the intruding B pillar. Remember that on a CT scan, we're looking at a slice of the body from below the feet, so the patient's left is on our right. You can see, however, the whitened area in the lung, which should appear gray. That's where the lung has been severely contused, and there's bleeding into that space, which is why it appears more white. But again, notice it's on the left posterior aspect of her body, which makes sense because that's where the B pillar was intruding into her seating space. Just below the lung contusion on the left side of her torso, she sustained injuries to her spleen from the intruding armrest on the door. The intruding door also struck her pelvis from the side, as evidenced by this bruise here. These x-rays and CT show multiple fractures to the left side of her pelvis, which resulted in a large amount of bleeding. The internal bleeding resulted in a hematoma that displaced and compressed her bladder in the bottom image. We've seen an example of a side impact case. If we were to look more broadly at all injuries sustained in such cases across the U.S., we would see that the head and chest injuries are most common, followed by injuries to the pelvis and the abdomen. Chest injuries are still quite common, but with better protection provided by side airbags, which are becoming standard in the fleet, we are seeing fewer aortic and heart injuries. Chest wall injuries, which can be accompanied by bleeding or pneumothorax, remain common and may increase, in fact, as the population ages, since elderly occupants are at greatly increased risk of chest injuries. Let's look at the most common specific anatomic injuries from side impact crashes in greater detail. This list has been sorted into clinical diagnoses that affect triage and medical care. Minor bruises and lacerations are common, but they're ignored. Based on current crash data, closed-hit injuries, including contusion and hemorrhage, are most common, followed by rib fractures and pneumothorax and hemothorax, pelvic fractures, lung contusion, femur fractures, splenic injuries, C-spine injuries, aortic and pulmonary vessels, skull fractures, and also diaphragmatic injuries. The final category of crashes that I'd like to examine as we think about the biophysics of motor vehicle crashes is a rollover crash. The trip over or tripped rollover is the most common type of single vehicle rollover crash. The event is caused by a sudden sideways slowing or stopping and induced by contact with a curb, a pothole, or pavement and soil being dug into by a vehicle's wheels. In this video, the car starts going sideways, the wheels snag, and the vehicle trips and starts rolling over. The physics of a rollover leads to very high centrifugal forces. What happens is that as the car starts rolling over, the occupants are sent by the centrifugal forces upward and outwards towards the windows. And what ends up happening is that this markedly increases the risk of ejection or contact with the outside ground, particularly if they're not properly belted. Let's look at this video of a rollover crash with 6 unbelted occupants of an SUV. The left panel shows the exterior view, and the right panel shows the interior view. During this rollover crash, notice that 5 of the 6 unbelted occupants are fully ejected, and that at least 2 of them are crushed between the vehicle and the ground during the rollover. You can see that during the rollover crash, the occupants are moved upward and outward towards the windows and are easily ejected once the glass is broken, if there's no curtain airbag. In summary, we've seen that motor vehicle crashes generate very large physical forces. Injuries are caused by these physical forces, which obey the laws of physics, hence they are predictable and dependent on the crash event characteristics. Injuries occur when physical loads are applied to tissues in a manner and with enough force to exceed the strength and tolerance of the tissues. These tissues are dependent on the condition of the occupant. Hence, risk of injury is affected by occupant characteristics. Automotive safety systems such as seatbelts attempt to prevent injuries by applying force over a longer period of time to the strongest parts of the body. Hence, risk of injury is affected by the appropriateness of restraint usage. Thank you very much.